speakers, please come upstage. So I think I'm going to start with a question to Jason. So why is the trial comparing IMRT and proton? Like if we are also concerned about the clinical benefit of IMRT, why isn't there a third arm that look at external beam in the case of the trial that you're discussing?
Yeah, so a third arm for 3D conformal radiation.
Right.
I think, unfortunately, the simple answer to that is the cat is out of the bag on that one. And so basically, as you saw, over 95% of U.S. External beam radiation delivery for prostate cancer is currently IMRT. To go back, and I think this gets to the de-adoption issue that was discussed nicely yesterday, it would be practically impossible. And there's probably sufficient amount of evidence that's been generated in non-randomized means to support the use of IMRT over 3D. But now I think proactively, the next generation has been proton therapy, and fortunately we're attempting to answer that question.
Okay. Oh yeah, Ralph.
I enjoyed the presentations very much. I had a question for Jason and a comment. So why, how big of the magnitude of benefit would there have to be for you to recommend proton therapy? So I noticed you have early stage and intermediate stage prostate cancer men in the trial. So it's likely that the low risk men are going to be surveilled and maybe half of the intermediate risk men. So there's unlikely to be a difference in survival. The second tumor, I would be very surprised given the age. It's possible, but even if it's statistically significant, it's unlikely to be significant for the individual. So what would you, how much of a difference would you want to see in rectal or bowel toxicity? And do you think it's realistic?
Yeah, no, I think that's a valid question. Clearly, surveillance, other means of management have really increased in use appropriately so in low-risk prostate cancer. The trial was really designed to be a pure radiation question, modality versus modality, and not be influenced by other therapies such as concurrent hormonal therapy. Ultimately, the benefit, you're right, I mean, this is generally an elderly or an older population, and late effects, rare late effects such as second cancers are unlikely to be, there won't be enough events to determine that. So ultimately the answer is really an issue of patient-reported outcomes as was described. There are a number of statistically accepted means for what is considered to be a clinically meaningful difference, and tends to be about half a standard deviation difference on the instrument that you're using, in this case EPIC, with bowel endpoints being the most specific sort of toxicity and quality of life issues related to prostate cancer. So I think that now, but you raise a really important question, which is, what is a clinically meaningful difference? And I'd actually love to hear Jim's thoughts on that.
Also, not only what's clinically meaningful, but how much is it worth? So if there's a 2% difference, even if it's a huge trial and it's statistically significant, is it worth $10 billion putting these things all over?
A very valid question, which is why a very important secondary objective of this trial are the cost effectiveness aims.
I would just add, the Mass General has a history of doing this right. It's not investor driven, it's been academic, it's supported by NIH grants. So I think you deserve tremendous, you and Herman going all the way back deserve tremendous credit for trying to answer this question in an appropriate way.
Yeah. And to address that, first of all, this is very much collaborative work. University of Pennsylvania intimately involved. All the centers, the NCI is the sponsor. So this is no one institution or one individual's work by any means. But just to get to your point, we are in a very robust way collecting cost data to inform your question, both direct and indirect costs, using healthcare utilization forms over time, developing relations with the payers to actually get real paid data. So hopefully that will help answer your question.
Just one other comment for myself. Well, I think the glioblastoma trial is wacko. that it's impossible. Yesterday it came up, there's no biological advantage to protons. It's a distribution question. Photons almost don't work. Protons are not going to work either. There's been numerous trials on high dose. I don't know why anyone would do this trial. It's sort of desperation. My comment is that this is a relatively small question, and it takes money out of basic research in the final analysis. And it makes us look bad with the rest of the oncological specialties. And I think it's a shame because I think that radiation biology has contributed a lot to oncology in general. And I mean, it's a reality, and it's really spurred by these investor-driven centers, as we heard yesterday.
We have to do the studies and the research. And that's, I mean, along your point. But maybe, can I ask Jim to answer the clinically meaningful question?
Yeah, that often when we're confronted with that, we toss it right back to the investigators, though, because you can always do a sample size in terms of a sort of synthetic measure, like a half standard deviation or something on a score. And in fact, that gives you really all the information you need, because you just need sort of a shift in the score. But it does need to be translated back into what does that mean in terms of a patient? How many points on a given scale means they're that much more miserable or so forth. And I think that's still kind of elusive. And I think increasingly, as we move really from a very sort of ad hoc methods and approaches to very rigorous sort of validated instrument approach, I think that's sort of raising the bar there. It sort of no longer flies to talk solely about the change as a percentage of the mean or something. We need to translate it back into what does that mean on the ground in terms of the patient's experience. It is elusive, and then you can go further from that, of course, and you get into utilities and what are patients willing to trade off and so forth. And that's been tried and used, but it comes at some considerable overhead to work through that, to even understand it, to make that a part of trials in a rigorous way. I think when Jason talks about augmenting his primary clinical endpoints with this other information, that's going to be the kind of trial that's really going to be the standard for the future in these technologies to measure cost and other aspects in a rigorous way as part of the trial protocol from the get-go.
I think of this in a simpler way. That I think of it and reframe it to think of it as a meaningful health outcome is basically something a patient can explain, not something that we explain. Shrinking a PTV, for example, is not a meaningful health outcome. It's a physics construct or it's a planning construct. But patients can describe back to you what a meaningful health outcome is. And then patients, as in their context of being part of society, can add the value piece to that discussion as well.
Next question.
So two-part question. One is, we have mobilized in the last few years by begging, borrowing, and stealing funds to initiate these trials, and I'm hoping by the end of this year we'll have 8 prospective randomized trials underway comparing photons and protons. We have been criticized by some people at the NIH as, why are you doing this Coke versus Pepsi trials when patients with pancreatic cancer and glioblastoma, the much more important challenges. So we're trying, but as Michael pointed out yesterday and today, that there is no other source of funding for these kinds of trials. I mean, industry doesn't fund these trials, FDA doesn't demand these trials, and insurers were claiming that they needed this evidence, but ironically, now that the trials are beginning, they might be undermined by insurance denials. So we have this very peculiar situation that I'm hoping by the end of the discussion today, we'll have some answers to. I have a specific question for Jim Dignam. One of the proposals to increase, quote, accrual, unquote, has been to allow, when we launch a randomized trial, to allow a companion registry for patients who refuse to be randomized. And the NIH leadership has been pretty insistent, at least intuitively, that that will undermine the randomized trial. But I was wondering if you know of any evidence whether having a companion registry with a randomized trial is likely to be harmful or beneficial.
I don't know of any offhand. So the idea is that because the registry is offered, the patients can opt out of the trial and get the treatment anyhow? Is that the idea, that the treatments are available via the registry as well as the trial? Is that how it's structured? You collect data on those who refuse, but the issue, I guess, where it would undermine the trials if they're permitted to access the experimental therapy, which in many cases could not be prohibited, of course, if it was proton therapy or something at a center. I don't know offhand of the sort of negative consequences it would have on the accrual to the study, if that's the aspect that they're focusing on as undermining. In terms of undermining, if that didn't happen and you just had this companion registry, of course, the great interest would be in the refusers, the people who join the registry. How are they different? How are they the same? Could they be analyzed side by side? And that'd be of great interest. That's why I mentioned it at the end, that I think this idea of combining, but I guess I didn't fully appreciate the idea that it could undermine the study if not carefully presented. And of course, it's a unique issue in these kind of studies versus drug trials, where you can just simply make the agents only available via the trial itself. But I guess the long answer to your short question is no, I don't know of any incidents where that's been the case, but we probably could look around and see if there are examples or counterexamples for that phenomenon.
In the prostate study, for patients who do not accept randomization or are insurance denied, we are collecting that information. So in that scenario, I think it does allow the potential powerful comparison, as Jim just described, and to look at how a non-randomized population may be generalizable to a randomized population or vice versa.
Yeah. So you're collecting that because they're consenting to some sort of pre-study presentation or something. That's always been the issue with our group. We've been, people have inquired for years, like, why don't you study the refusers? Why don't you study those who didn't enter the study, and why, and so forth? Well, you need to consent them into some kind of study that envelops the other study, and we don't really have the resources for that, or the proposals that have been put down have not succeeded. So we don't know what we're not studying there, but it would behoove us to study that whenever we can.
Okay, so let's move on to the next question.
Hi, Stephen Williams, MD Anderson. So I had a question regarding, for Jason, regarding the particle study. Although, it's assessing the quality of life, my question is in regards for the overutilization of, active treatments in low-risk prostate cancer in general, and considering my work as well, is that, wouldn't it be also probably prudent to look at intermediate and high-risk disease to get the secondary endpoint being oncologic efficacy? Because that's the premise for delivering these treatments. And then also, too, there's, subcategories within intermediate risk prostate cancer, those that have favorable and then unfavorable characteristics. With, my training at the Brigham with Anthony D'Amico, knowing those subclassifications, because that seems to be the prudent area where we're looking not only at the quality of life, but also to the oncologic efficacy.
Yeah, no, entirely agree with the good question. And, ultimately, this was a trial designed to be, as I described, a pure radiation comparison trial and not be confounded by issues of quality of life effects of hormonal therapy, which we know are significant. We toyed with the idea that it would have been a much bigger study. As has been highlighted, these studies are difficult to accrue to begin with, to sort of study many different populations and stratify for them. I think, exploring, in studies such as this, if there truly ultimately is concerns on reaching accrual broadening eligibility, is one potential option. But you're right, and hopefully our data from this trial, and the patients who enter this trial have been presented all options regarding active surveillance and other local therapy management options. But hopefully some of the data from this trial will address the efficacy in the spectrum of intermediate risk disease.
Hi, I'm Sean Tunis from the Center for Medical Technology Policy. Great panel, great presentation. So I guess this question is mostly to Michael, but it relates to this issue raised about the magnitude of potential benefit, protons versus IMRT. And it goes back to the CTAF framework that you described, Michael, the ICER sort of model. And they did the review of proton beam and IMRT that you mentioned. And you talked about part of the model being that one of the things that's considered is level of certainty. And it seems to me as what I'm wondering is whether the determination of the value of a technology in the CTAF model is sensitive to the level of certainty about incremental benefit. So in other words, if Jason finishes his trial and shows that proton clearly has a small incremental benefit in terms of colorectal, proctitis, will that in some way, if it's sort of high certainty that it's a small benefit, does that, improve the situation in terms of the calculation of value over what we already know, which is there's a small chance that there might be a small benefit. Do you see what I'm saying? So I just wonder how the model will deal with somebody to go to all the trouble and expense of doing a trial when in fact the result, probably the best case, is going to be high certainty that it's a small benefit, in which case the payers might as well just pay the same for IMRT and proton because it's not going to be worth a lot more anyway.
And I was referencing that in the talk, and we've started to get into that. Without talking about reference pricing per se, what it's all about is looking at incremental benefit and what that cost is. And then you make a determination in the second phase of the process, is that cost worth it? Or what they did with the hepatitis C drugs, can you mitigate the cost of the drugs by political influence, press, whatever, patient advocacy groups, to make it make sense. Right now, so you know, CTAF, which was much more technology-focused previously, is much more drug-focused right now because of this onslaught of very expensive drugs. So they're going to start looking at, drugs, this new cholesterol specialty drug, which could be a $100 billion drug. What's the societal benefit when you put in the cost? And so that's those judgment points that the panel makes. And it's important to note that the panel is more than multidisciplinary medical. It includes ethicists, it includes patient advocates, and so forth. So, and methodology experts as well that keep us honest as we go through the process. Does that give you a sense?
It does.
I know you know Steve well and probably know the process better now.
Well, I don't want to take up everybody's time, but I do think that unless the mechanism applies some economic value to greater certainty, there's not going to be much incentive to invest in studies like the one Jason's doing, because if you show a small benefit and you're only willing to pay an amount that's commensurate with the benefit and insensitive to the certainty, there's no incentive to do the research.
So the panel meetings are open both in the Northeast and in San Francisco and LA. And I think if you see the deliberations, what you're bringing up is clearly taken into consideration, comes out in the discussion and comes out in the policy discussion as well.
Okay, so in consideration of time, we're going to take one more questions. If you have other questions, save your question. There will be another Q&A session at the end of the panel session. Yes.
Just quick question for Dr. Stafu. Can you talk about the practicality and the scalability of the Blue Cross Blue Shield program in Massachusetts, whether that could be something that's particularly unique to the area where you did it, or whether that has aspects of it that could be replicated nationwide or in other markets?
It's a great question. I do think it's scalable. I mean, it's shown feasibility, relatively easy to introduce, short-term positive results. Why shouldn't it be Blue Cross Blue Shield's national policy? I mean, as we know, state-by-state policies vary dramatically. I think Blue Cross Blue Shield has been proactive in Michigan as well. They're helping support a real registry on IMRT utilization in breast and lung cancer. University of Michigan and other care providers in Michigan are actively participating on that, looking at issues of utilization, quality of life, toxicity. So I think there are proactive collaborative models for engagement with payers. And I would hope that one recommendation that comes out of this meeting is that we should engage those and really try to promote those. As Vic highlighted, as I highlighted, these studies their accrual is threatened by coverage denial. The lung trial that Jim showed results for has about a 30% coverage denial factor to it. And if that means we're bringing the evidence to the table in a much longer time frame due to these kinds of barriers, I mean, this is surmountable with feasible examples such as the case in Massachusetts. So yes, I think the answer is yes.
Okay, so I think we're going to take a short break and come back in 10 minutes. Thanks, the speaker, for a wonderful presentation.